Sir, now we can start. We are on live.
Okay. It's audible, clear?
Yeah, you are audible, sir, and clear. Perfect.
Yes. Good evening, respected members of Indian Society of Anesthesiologists. Welcome to today's postgraduate training program by ISA Kerala State Chapter, the PG update. Today we have two very interesting and important topics. The first lecture is on closed circle system, a definite question for the postgraduates, either in the theory or the viva. We have Dr. Nahid Assar, who is the professor at Department of Anesthesiology, Madras Medical College, Chennai, an eminent and well-known teacher. I take this opportunity to welcome our esteemed faculty today, Dr. Nahid Assar, on behalf of ISA Kerala State Chapter. The second part of today's talk is on airway ultrasound. This is a topic which is important and interested for both of us, because we are all experts in ultrasound regional anesthesia. Now it is time to move on to airway ultrasound. We have the well-known teacher, Dr. Joseph Rajesh, who is professor and head of Department of Anesthesiology, Indira Gandhi Medical College and Research Institute, Puducherry. I take this opportunity to welcome Dr. Joseph Rajesh to today's PG update. I am happy to welcome our President-elect ISA National, Dr. Venkatagiri KM, who is the mastermind behind all of our academic and organization programs. Dr. Giri, welcome to this meeting.
Thank you.
Today's scientific sessions are moderated by Dr. Rajesh MC, who is Scientific Chairman of ISA Kerala State Chapter, and Dr. Vijesh Venugopal, who is the Governing Council Member, ISA Kerala State Chapter, and Professor and Head of Department of KMCT Medical College, Kozhikode. I welcome Dr. Rajesh MC and Dr. Vijesh Venugopal. I also welcome our Vibrant Secretary, Dr. Bill Isaac Matthew, to this meeting. I welcome all our teachers, postgraduates, and our members of ISA family to today's meeting. Now over to Dr. Giri for a few words as the opening remarks. Dr. Giri, please. Dr. Giri, please. Dr. Giri is muted.
Yeah, I am unmuted.
Yeah, please,
Yes,
sir.
please.
Thank you for your
I am
remarks.
unmuted.
Please, your opening remarks for us.
Good. Okay. Dear President Nazar, Secretary Binil, and our faculties, Dr. Nahid Azhar and Dr. Joseph Rajesh, our scientific coordinators, Dr. Vijesh and Rajesh, good evening all. In our endeavor to give good talks by renowned faculties who are crowd pullers and attractive from all over the country and maybe from outside. We have two eminent speakers, Dr. Nahid Azhar and Dr. Rajesh. People will understand only when they hear them and how they take the class, how they prepare and take that. Even when we ask that, you are told him, sometimes they say we need some time to prepare and they take the talk, not like anything. So, so far we have succeeded in all that. Hope we will succeed all throughout. But it is for the PGs to take benefit of this and attend the seminars every Saturday. So I welcome all the faculties, all the PGs, and you all for this. And thank you for Dr. Rajesh and I mean Joseph Rajesh and Dr. Nahid for accepting doing this. Thank you. Over to you.
Thank you, Dr. Giri. We will straight away go to the academic part. I request the webinar coordinators of our meeting, Dr. Rajesh and Dr. Vijesh, to take over and proceed the academics.
Thank you, Dr. Nazar, President ISA Kerala State. It's a pleasure to introduce Professor Nahid Azhar, who is a professor of anesthesia at Christian Medical College, Madras Medical College, Chennai. He's an alumni. He did his both the DA, MD, and DNB from Madras Medical College, and is a well sought after faculty. So this we have two sessions today. One is closed circle system, and second is airway ultrasound, which is of practical relevance to our general anesthesiologists, practicing anesthesiologists, as well as for the postgraduate students facing practical examinations. Over to Dr. Naheed sir, and welcome to ISA Kerala webinar.
Respected teachers, practitioners, and students of anesthesiology, good evening. At the outset, I'd like to thank Professor Dr. Venkatagiri and Professor Dr. Binil for having given me an opportunity to be a part of this teaching program. And today I'm going to talk to you about one of the commonly used circuit in anesthesia, which is the closed circuit, also called as the circle system. The references I'll be using are from Miller 9th edition and from Understanding Anesthesia Equipment Doshin 6th edition, and from a website called capnography.com, and some product monograph about the latest developments in soda lime absorption. Now, there are several classifications of breathing circuits have been available over various periods of time. The latest classifications are the Conway classification and the Baraka classification. The Conway classification says that breathing circuits are classified as breathing systems without carbon dioxide absorber or breathing systems with carbon dioxide absorber. Without carbon dioxide absorber are your Mapleson systems. Breathing circuits with carbon dioxide absorption can either be a bidirectional flow, which is a to and fro canister, water canister that is become historical nowadays. And the unidirectional flow is a circle system that you use with a soda lime canister. Now, the circle absorption system makes sure that gas flows in one direction, and it ensures that there's a circular flow of gases. And this it achieves by putting certain components together. And what are these components? There are two 22 mm ports, which are the inspiratory and the expiratory port. There is a reservoir bag. There is an absorbent canister containing the soda lime, and there's a port for fresh gas flow. And there are two unidirectional valves sitting above these ports. One is an inspiratory unidirectional valve, and the other is an expiratory unidirectional valve. And if you put them together, the components work like this. From the canister on the inspiratory limb, you have the fresh gas flow. You have the inspiratory unidirectional valve. The inspiratory limb comes down and comes to the patient head where it connects to a Y-piece. On the expiratory side, from the Y-piece, you have the expiratory circuit with the expiratory unidirectional valve. And then you have the APL valve, the reservoir bag, and then the gas enters the canister, which contains the soda lime, where absorption of carbon dioxide occurs. This is the classical circle system. But the modern circle system that occurs in modern anesthesia workstation contains many more parts. These include an oxygen sensor, a humidifier, a heat moisture exchanger, a gas sampling line, a airway pressure sensor, PEEP valve, a pressure gauge, and a selector valve that toggles between a reservoir bag and a ventilator. All of these have now become a part of a modern circle system. So a modern circle system looks a little like this. These are your two unidirectional valves. The oxygen analyzer sits on top of the inspiratory unidirectional valve. That's your pressure monitor. That's your volume measuring device. Your ventilator sits underneath it. This is a pressure regulating valve. That's your scavenging unit out there. And there's a special valve whose function we'll see a little later. No matter whether it's a classical or a modern circle absorber, the working system remains the same. The gas flows only in one limb at a time in a circular manner. During inspiration, what happened? The inspiratory unidirectional valve opens. At that point of time, the expiratory unidirectional valve is closed. Gas flows from here, the fresh gas flow joins it, and through the inspiratory limb, it picks up the vapor and goes to the lung. So the gas is flowing in only one direction. At expiration, what happened? The inspiratory unidirectional valve closes. The expiratory unidirectional valve opens. Now gas from the lung flows along the expiratory limb, comes to the reservoir bag, opens the APL valve. A little of it can be lost to the atmosphere, but basically it passes to the canister where the soda lime will absorb all the carbon dioxide that has come in the expired gas. Now, different components can be placed in different places. Like if you see the FGF, it can be placed in 5 different places. Usually it is placed distal to the canister into the inspiratory limb. Also, the reservoir bag can be placed in several places. Usually, it's preferred to be placed on the inspiratory limb just after the canister. Because if you place it on the expiratory limb and you do IPPV, there is a possibility that the dust that is there in the canister can reach the patient's lung. And the APL valve, once again, can be placed in several places. Usually, it is placed on the expiratory limb just before the canister so that the gas that is vented to the atmosphere is the expiratory gas that is rich in carbon dioxide so that your soda lime is not wasted. no matter what permutations and combinations you use your various components in. The circle system will work as long as you obey the 3 cardinal rules of the circle system. And what are the 3 cardinal rules? Rule number 1, you need 2 unidirectional valves. One unidirectional valve should be located between the patient and the reservoir bag on the inspiratory limb. And the second unidirectional valve should once again be located between the patient and the reservoir bag on the expiratory limb of the circuit. Second cardinal rule, FGF inflow cannot enter the circuit between the expiratory valve and the patient. If it does, it'll get vented out through the expiratory valve and will offer unnecessary resistance to the exhalation of the patient. So FGF cannot enter between the expiratory valve and the patient. And third, the overflow valve or the APL valve cannot be liquidated between the patient and the inspiratory valve. If that happens, inspiratory gas, instead of going to the patient, will get vented out through the APL valve. So as long as these 3 cardinal rules are met, your circle system will work fairly all right. Now let's look at the components that go to make a circle system. First, we look at the unidirectional valves that are known by several other names. The disc itself is made out of plastic, mica, or ceramic. It consists of a dome. It consists of a cage that holds the disc valve in it, and this disc sits on a seat. If you open it and see, you can see the dome is in the hand of the observer. That white piece you see is the disc, which is actually the valve, and the metal piece around it you see is the cage that keeps the disc in the proper position. And you can see this opening. This is the seat on which the disc is going to sit. So the UDV valve, the disc is usually larger than the seat. The UDV valve can malfunction. When it malfunctions, it is called as an incompetent UDV valve. The incompetent unidirectional valve usually gets stuck in an open position. And when it gets stuck in an open position, it becomes incompetent and it offers less resistance to flow of gas. And you know that gas will flow through the area where there is less resistance. So when a valve is stuck open, whether it's inspiration or expiration, the gas will only flow through this incompetent valve because it offers less resistance. And therefore, the entire circuit will become a dead space circuit. Patient will have rebreathing, and so the PaCO2 and the EtCO2 will start to raise. And usually the valve that gets stuck open and becomes incompetent is the expiratory unidirectional valve. And this stickiness occurs due to the moisture from the exhaled air, due to electrostatic forces, and also due to dirt accumulating in the expiratory unidirectional valve. Rarely, the unidirectional valve can get stuck in a closed position where it can produce total occlusion and barotrauma. And in such a situation, you'll never be able to ventilate the patient. So you should exclude the circle system, or you should exclude the machine when you get into a scenario like this. The working principle of the unidirectional valve is slightly different for the inspiratory valve and the expiratory valve. In the inspiratory valve, you'll find that the gas coming from the machine actually comes to the inspiratory valve. It elevates the disc of the unidirectional valve in the inspiratory valve, and then it flows towards the patient into the inspiratory limb. On the other hand, the expiratory valve, what happens? The gas comes from the expiratory limb from the patient, and this expiratory limb is directly attached to the expiratory unidirectional valve. It lifts the seat from the seat, it lifts the valve up, and then the gas flows into the port from where it is taken to the suckle absorber, where the absorption of the carbon dioxide will occur. So how do you know whether the unidirectional valve is working properly or not, or it has become incompetent? One of the methods is to observe the movement of the unidirectional valve. That becomes a bit of a problem if the moisture blocks your vision. The best way to look whether the unidirectional valve is working or not is to look at your EtCO2 tracing. If you look at your EtCO2 tracing and your 2 unidirectional valves are working all right, you'll find that the EtCO2 is normal, the tracing looks normal, it reaches the baseline, and the inspiratory carbon dioxide is 0, and the beta angle is 90 degrees. Now, if the unidirectional valve, for example, here the expiratory unidirectional valve has stuck in a open position and has become incompetent, what happens? There is an increase in EtCO2, hypercarbia occurs, inspiratory carbon dioxide goes very high, the tracing will not touch the baseline, and you can see that the beta angle increases beyond 90 degrees. So EtCO2 can be used to monitor the functionality of the unidirectional valves very, very well. The old machine, the unidirectional valves were horizontally placed and they had to be lifted. So this is what you see in an old machine, horizontally placed valve. And this is the expiratory valve. You can see how the moisture is blocking the vision of the unidirectional valve and cause stickiness. In modern workstations, they have put the unidirectional valve in a vertical disposition. Therefore, they need not be lifted. They just have to be tilted. And tilting is easier than lifting. And therefore, in modern machines, vertical unidirectional valves are preferred. Next, we come to the canister, which is also called the brain sword canister. It is made out of transparent material so that you can see it. It usually has two canisters in a position, and there's a screen that holds the absorbent in place. And the canisters are available in two sizes. In modern days, even disposable, ready-to-use canisters are available. The classical canister that we use is called as a jumbo canister that has got two chambers in a position. It roughly holds about 1.7 to 2 kgs of soda lime. It has a large absorptive capacity of 17 to 20 liters of carbon dioxide per 100 gram and can be used for a long duration of about 12 to 15 hours. And its advantages are it is more efficient. It offers a large cross-sectional area for absorption of carbon dioxide and produces less dust migration. But the problem is it can produce more carbon monoxide formation. The second type of canister is a smaller canister, which in some literatures has been referred to as the Scandia absorber. It only holds half kg of soda lime. It has a decreased absorptive capacity and can be used only for shorter duration of 2 to 3 hours. Advantages being it has fewer leaks, it's easy to clean, it is easy to change, and can be used in a disposable manner. But the disadvantage is it requires frequent changes and therefore is less efficient. In modern workstations, you have an intermediate size canister that holds about 7.5 to 1 kg of soda lime. And in some modern workstations, even when the patient is being ventilated, temporarily you can remove this canister without interfering with the ventilation and change the soda lime. How does the carbon dioxide absorption occur? Is there a particular pattern? For this, let us assume that the exhaled air enters the canister from here and passes downward. As the gas enters the canister, it comes with contact with the granules on the top. And the carbon dioxide gets absorbed here first. And so the granules on the top get used up first. And then you can see that the granules on the side are getting absorbed, are being utilized. That is because gas flows preferably along the sides because the walls here are straight. This ability of the gas to flow on the sides, thereby utilizing the soda lime on the side, is called as the wall effect. And as the more and more soda lime gets used up, you will find that the wall effect still continues to happen. Finally, when the entire soda lime is used up completely, you will find still there is a small area of soda lime that is not used. And this is called as the blind spot. In all canisters, a blind spot exists that sits in the distal 1/3 of the canister, in the middle portion of the distal 1/3 of the canister. So a blind spot is seen here. And when you pack the soda lime in your canister, some areas get packed very tightly and some areas don't get packed very tightly. And you know that gas follows the path of least resistance, and the least resistance will be where the soda lime is not packed very tightly. And the gas following this mechanism, this pathway, utilizes the soda lime along this pathway. And this mechanism where gas flows through a particular pathway that has less resistance and utilizes the soda lime there is called as channeling. Therefore, wall effect, blind spot, and channeling are part of all soda lime canisters. As far as the carbon dioxide absorbent is concerned, the traditional old absorbent are soda lime and barrel lime, and the newer one are the calcium hydroxide lime, and the latest is the litho lime. Let's look at the classical soda lime, which is the wet or high moisture variety that has a great absorptive capacity of 25 liters of carbon dioxide per 100 gram of soda lime in ideal condition. It contains calcium hydroxide 94%, sodium hydroxide 4%, which improves reactivity, is hygroscopic and improves binding. Potassium hydroxide 1% increase reactivity in cold. Sodium hydroxide and potassium hydroxide are basically the catalysts. They are necessary to start the reaction in soda lime. Water 14 to 20% initiates the reaction. Silica 0.2% is a hardener and prevents dust formation. Kieselguhr is a hardener clay that maintains granule size and porosity. And the indicator that is used in the old soda limes is Mimosa Z that converts from pink to white. So the traditional soda lime contained a high percentage of catalyst, sodium hydroxide and potassium hydroxide, and both of these generated a lot of heat. And a dry and desiccated soda lime was very, very dangerous because it produced dangerous breakdown products with modern inhalation agent. It produced heat energy, and it did not ensure that the indicator changed its color when it was utilized. The color of the indicator came back to normal, which was a phenomenon was known as regeneration. And the absorptive capacity of dry soda lime was greatly decreased. And it also had a tendency to absorb and hold inhalation anesthetics. Therefore, the traditional soda lime had a lot of problems. The indicators we use in the old soda lime is Mimosa Z that converts from red to white when it gets completely utilized. But in modern absorbents, we use ethyl violet that converts from white to purple. But remember, when this ethyl violet is exposed to strong fluorescent light, it can change its color. The indicators are based on the fact that the acid or base that is used, its color depends on a particular pH. And the dividing pH that is used in most of the indicators is 10.3. If the pH changes beyond 10.3, which happens when the absorbent gets used up, then the indicator changes its color. And when the indicator changes its color, it tells you the absorbent has lost its ability to absorb carbon dioxide. Shape, size, and hardness of soda lime of any kind is very important. It is either available as granules or as pellets, or it's available as spears. And the size is 4 to 8 mesh size. What do you mean by 4 to 8 mesh size? You take a 1-inch mesh, and each 1 inch you divide it into 4 1/4-inch openings. That is 4 mesh. If you divide it into 8 openings, that is an 8 mesh. So your granule should pass through a 4 mesh screen, but it should not pass through an 8 mesh screen. That size of granule is called as a 4 or 8 mesh size granule. And it has to have a certain amount of hardness so that it does not break down into powder easily. And that hardness number is 75, and that hardness is produced by kieselguhr and silica. Because it breaks down, it produces dust that is called as fines. And if this dust is pumped into the lungs of a patient, it can produce a reaction in the lung and an inflammatory process. Sometimes this powder can mix with the moisture and can produce a phenomenon called as caking that can increase the resistance offered to flow through a soda lime canister. This shape, size, and hardness are very important because they offer low resistance to flow, they decrease the channeling, at the same time they offer more surface area for carbon dioxide absorption. So the carbon dioxide absorptions have undergone a sea change from the classic soda lime that was originally used to the nude soda lime and much newer agents now. So what changes did they produce? First, they started decreasing the potassium hydroxide. You can see finally in new soda lime, they completely took away the potassium hydroxide from the soda lime. And in the latest calcium hydroxide lime and litho lime, they also took away the sodium hydroxide along with the potassium hydroxide. And finally in Spiralith, there is no calcium hydroxide also, there's no sodium hydroxide, there's no potassium hydroxide, there's no water. Just with lithium hydroxide, you're able to absorb carbon dioxide. So removing this catalyst was a very important step in making absorbents more safe. What is the chemistry of absorption with soda lime? It's basically a base neutralizing an acid. So how does the reaction start? Carbon dioxide is a gas, so it cannot be absorbed just like that. So what it does, it mixes with the water that is present in the soda lime, or it comes in the expired air and forms an aqueous carbonic acid. The carbonic acid then reacts with sodium hydroxide and potassium hydroxide, which are the catalysts, which are necessary for starting the reaction, and produces sodium carbonate, potassium carbonate, and 2 molecules of water. More molecules of water are produced than are utilized, and it produces a large amount of heat energy, showing that it's an exothermic reaction. Then the sodium carbonate and potassium carbonate finally reacts with calcium hydroxide to produce calcium carbonate, and that leads to regeneration back of sodium hydroxide and potassium hydroxide, which are the catalysts, and once again heat is produced, showing it's an exothermic reaction. So carbon dioxide absorption is an exothermic reaction, producing 13,700 calories per mole of carbon dioxide absorbed, and it produces more water than it uses up, and it produces a change in pH, which allows indicator to be used. This exothermic reaction offers certain advantages. It warms the fresh gas flow, it produces partial humidification, and it also has certain disadvantages because this heat can lead to increased breakdown of inertial agents with soda lime. Next, we come to barium lime that can absorb about 27 liters per 100 gram. I have never used it. It contains calcium hydroxide 80%, barium hydroxide 20%, water for crystallization as octahydrate 11 to 16%, potassium hydroxide 16%, and the usual indicators. And the absorption is much the same like soda lime. Calcium hydroxide lime is the newer lime, which is safer, but it's got lesser absorptive capacity of only 10.2 liters per 100 gram, contains calcium hydroxide 75 to 83%, no sodium hydroxide and potassium hydroxide, calcium chloride as humectant 1%, calcium sulfate as hardener 1%, polyvinyl pyrrolidine as a hardener and porosity 1%, and water content of about 14%. Here in the reaction, carbon dioxide plus water produces carbonic acid with reaction with calcium hydroxide to produce calcium carbonate, once again water, and releases energy, heat energy, showing that's an exothermic reaction. Calcium hydroxide is much superior than soda lime, contain no sodium hydroxide, potassium hydroxide, so no regeneration, color change of indicator is permanent, no degradation of anesthetics, no carbon monoxide, no compound A, no formaldehyde, and less nephrotoxicity. But the disadvantage is it has got less absorptive capacity. If you look at compound A generation with soda lime, as you give anesthesia for longer time, the compound A keeps on increasing with sevoflurane, but with calcium hydroxide lime, there's absolutely no compound A production. Likewise, if you look at the carbon monoxide production, whether with des-enflurane or isoflurane, if you use soda lime, the production of carbon monoxide is between 500 to 600 ppm, but with calcium hydroxide lime, it is practically zero. So these are the advantages. The latest in carbon dioxide absorption is the litholime. Litholime is a lithium hydroxide lime that is free of sodium hydroxide and potassium hydroxide. It has lithium chloride added to it as a catalyst to accelerate the reaction. Now, lithium hydroxide combines with carbon dioxide and utilizes heat. It's an endothermic reaction to produce lithium carbonate and once again releases water. And advantage of litholime is when calcium hydroxide lime absorbs lesser amount of carbon dioxide when compared to soda lime, the litholime can absorb almost the same amount of carbon dioxide as your standard soda lime, and therefore it is better than calcium hydroxide lime. The indicator that is used in litholime is ethyl violet. And lithium hydroxide is available in two forms, anhydrous form and monohydrate form. Anhydrous form does not have water, therefore it requires water for hydration, which comes from the expired air of the patient, and this can lead to a little bit of heat generation. We don't want that. Therefore, we use a prehydrated lithium hydroxide called as lithium hydroxide monohydrate, LiH2O, which is prehydrated at the factory. When you use this, your reaction of carbon dioxide absorption is an endothermic reaction, and therefore heat generation becomes much more lesser, and the rest of the problems are all avoided. The latest in absorption of carbon dioxide is a solid absorbent using lithium hydroxide called spiraleth. Spiraleth occurs like this. It's lithium hydroxide powder enclosed in a polymer sheet, and this absorbent is recyclable. When it is used up completely, you can take it out, you can recycle it, impregnate it again with lithium hydroxide powder and reuse it. There's no dust, there's no degradation of inhalation agents, and there's no desiccation. The other important thing with spiraleth, it's got a color indicator window system here. It tells you if the inspired carbon dioxide concentration increases 0.5%. And it uses ethyl violet as an indicator, and the amount of ethyl violet used is extremely low, almost 1,000 times low. So what happens is, when the first indicator starts changing blue, the inspired carbon dioxide is 0. When the first one becomes completely blue, the inspired carbon dioxide is still 0. When the second starts becoming blue, the inspired is 0. When the second is completely blue and the third starts becoming blue, its inspired carbon dioxide is still 0. When the third starts becoming blue, almost getting completed blue, the inspired carbon dioxide is 0.6 millimeter per mercury. When the third is completely blue and the fourth is now completely blue, the inspired carbon dioxide is only 3.6 millimeter of mercury. And now is the time to change your spiraleth. So the point here is the inspired carbon dioxide remains at or near 0 until 3 bars have turned blue. And so when the 4th bar turns blue, you have to change it. And even then the inspired carbon dioxide is much within the safety zone. Next, we come to the APL valves. APL valves are of two kinds in the machine. In the older machines, you had this kind of APL valve, which was called the variable orifice or the resistor type, where you opened up and there was a spring-loaded disc there. It just adjusted the orifice size, which allowed when the gas pressure inside the circuit increased this opening pressure, it allowed the gas to be vented out. This adjustment was only related to fresh gas flow rate and how you squeeze your reservoir back. The pressure was never absolute and you could not measure it at all. So the newer kind of machines have an APL valve, which is a pressure regulating type of valve. In this, you can see there are markings. It can tell you definite pressure at which this APL valve will open. If you open it to the spontaneous mode, you will find that it completely opens to the atmosphere or to the scavenging system. In modern, like say, difficult intubation, RSI, modified RSI, you are allowed to ventilate the patient provided you keep the pressure less than 20 mm of mercury. In valves like this, pressure regulating valves like this, what you can do, you can set this APL valve at 20 And if you ventilate the patient, the pressure in the system will never go above 20, because if it goes above 20, the APL valve will open and allow the gas that is being pushed to be brought out to the scavenging system. So this is the latest in APL valve. Reservoir bag is a part of circle system. It performs the normal function that you expect a reservoir bag to perform in any circuit. The corrugated tubing have a length of about 1.6 to 1.8 meters. These are compliant circuits. So they expand during inspiration and may collapse during expiration. And this leads to a small amount of volume loss, which is not acceptable. So modern workstations, before you start using them for anesthesia, do a compliance to test to check the compliance of the circuit. And they're able to produce a compliance compensation. Thereby they ensure that the set tidal volume on the ventilator is delivered exactly to the patient. And finally, there is the Y-piece here. The Y-piece attaches the circuit to the patient end, and it behaves in two different ways. If you connect the endotracheal tube connector or a LMA connector, it behaves like an 15 mm female connector. On the other hand, if you connect it to a face mask for face mask ventilation, it behaves like a 22 male connector. And these are the components that go to make a circle system circuit. There is a circuit called as a coaxial system, a single limb circuit that goes by the name of King circuit or Mira F circuit or the universal circuit. This is used for easy handling single limb circuit. So here the inspired gas comes in the inner limb and the exhaled gas goes in the outer limb, just like the Bain circuit. And if the circuit is working well, the dead space is only till here. But if there's a break in the inner circuit, the whole limb can become a dead space circuit, or the inner limb can retract, when this area will become the dead space circuit. And you have to be very, very careful when you're using a single limb circuit, and you have to test it probably the same way as you would test a Bain circuit. There is a bag ventilator switch, and if you take it on to spontaneous ventilation, the ventilator is excluded, but the reservoir bag and the APL valve are included in the circuit. If we switch the switch to the ventilator form, then the APL valve and the reservoir bag are excluded from the circuit. Does the circle system have a dead space? All circle systems have got an apparatus dead space. A circle system also has got a dead space. It is at the junction of the Y piece. This is where the inspired gas, fresh gas flow, and the exhaled gas from the patient meet. So we'd expect the dead space to be till here. But if in reality, you will find that the dead space extends a little into the inspiratory and expiratory limb. This is because a little bit of time is taken for the closure of the two APL valves, and it causes the exhaled air to move into both these limbs, and this phenomenon is called as backlash. So actually in clinical practice, the dead space of a circle system looks like this. But if your expiratory unidirectional valve becomes incompetent, the entire limb becomes a dead space, apparatus dead space. It leads to an increase in dead space and leads to rebreathing of carbon dioxide and could produce hypercarbia. Functionally, based on fresh gas flows, the circle system is classified, which defines the amount of rebreathing that is going to occur and the conservation of exhaled gases. When you use flow rates more than 3 to 4 liters, it is called as a semi-open system. In this flow rate, very minimal rebreathing occurs and there's significant wastage of gases that you're using. A semi-closed system uses flow rates between 1 to 3 liters. Probably majority of us use the semi-closed system. And in closed system, the flows are usually less than 1 liter. In this closed system, you have maximal rebreathing and least wastage. And a circle system should preferably be used as a completely closed system. Because if you use flow rates less than 0.5 liter, the rebreathing will be almost 90%. Even if you use 1 liter of flow, the rebreathing is somewhere around 60%. And if you use flow rates more than 6 liters, there is zero rebreathing. The system behaves completely like an open system and does not require soda lime to be present in your soda lime canister at all. So using flow rates above 6 liters is a waste of time and soda lime when using a circle system. What are the toxic degradation products the soda lime produces when you use it with modern inhalation agent? Compound A with sevoflurane, which has potential nephrotoxicity, carbon monoxide, these two are big problems. And sometimes the inhalation agent can get absorbed onto the dry soda lime. It makes induction and deepening of plane of anesthesia difficult. Intense heat can be produced that can provoke fire accidents, and methanol and formic acid can also be produced by sevoflurane. And heat is generated basically by soda lime because it's an exothermic reaction. Temperatures in excess of 400 degrees centigrade have been recorded, leading to melting, deformation of plastic components, explosion and fire. It is important to monitor the temperature and moisture content in the circuit. And when you use sevoflurane with desiccated soda lime and barrel lime. It can produce carbon monoxide, formaldehyde, formic acid, and methanol. And this production can also occur with lithium hydroxide if you're using the anhydrous form. Therefore, use lithium hydroxide in its prehydrated form. This compound A is a CO-olefine halide, which commonly occurs in low flow or closed circuit anesthesia when you're using very high flow of a concentration of sevoflurane, and your soda lime contains potassium hydroxide and sodium hydroxide, and your absorbent temperatures are very, very high. Therefore, FDA says that if you are going to use sevoflurane for more than 2 Mach/hour anesthesia, it is better to keep the fresh gas flow rate between 1 to 2 liters. So if you are using sevoflurane for more than 2 Mach anesthesia with soda lime, better not to use flow rates less than 1 liter per minute. Although modern days, several publications are available where they use flow rates less than 1 liter quite safely. And in my clinical practice, I've used sevoflurane in flow rates less than 1 liter per minute, and I've had no issues. Carbon monoxide is commonly produced in barrel lime more than soda lime, most commonly with desflurane, more than enflurane, more than isoflurane, and least commonly with halothane and sevoflurane. Same reasons are there like desiccation and sodium hydroxide and potassium hydroxide that produce more carbon monoxide. Absorbent tends to get desiccated. Water is a major component. It is necessary for starting the chemical reaction. If this absorbent dries, it causes all kinds of problems. And this drying can also occur if there is retrograde flow of fresh gas flow through the absorber. You should not do it. So don't leave gas on flow unnecessarily. Do not keep the circle system without being used for a prolonged time, and never use oxygen therapy through the circle system. The common avoidable problem is you give regional anesthesia, and to give oxygen therapy, you attach it to your circle system at the YPs, and this causes drying of the soda lime, which can produce all kinds of problems. Is barotrauma possible in the circle system? Normally in traditional ventilators, if you put a tidal volume, the tidal volume is delivered by the ventilator, but the fresh gas flow that you have set up also keeps getting added to this ventilator delivered tidal volume. So it produces an increase in tidal volume. In normal healthy adults, this might not be a problem. But in pediatrics, in non-compliant lungs, and in patients with COPD, this increased delivery in tidal volume can produce barotrauma even in the circle system. Therefore, newer monitors are being put in to make sure that this does not occur. And one of the commonly used things is a component called as fresh gas decoupler that sits like a valve here on your circle system, modern circle system. The fresh gas decoupler is a valve placed between the ventilator and the fresh gas inlet. So during inspiration, what happens? As the ventilator is pushing through air through the inspiratory limb to the patient, the fresh gas decoupling valve is closed. So the fresh gas cannot be added on to the inspiratory limb. Instead, it gets diverted to the reservoir bag. So it cannot produce increase in tidal volume, and barotrauma cannot be produced. But during exhalation, what happens? As gas flows through the expiratory limb, this fresh gas decoupling valve is opened, and now fresh gas flow along with the exhaled air coming out of the canister is allowed to flow towards the ventilator. Therefore, during inspiration, additional volume is not allowed to go into the inspiratory limb. So only the set tidal volume is delivered. There's no increase in pressure. So barotrauma is avoided. Can the adult circle system be used in pediatrics, or is there a separate circle system for pediatric patients? It all depends upon what resistance the circle system offers to breathing. If you look at the resistance offered, the least resistance is offered by pediatric Mapleson circuits, which is your Mapleson ENF. They offer lesser resistance than circle absorber. But the circle absorber offer lesser resistance than coaxial systems like Bain circuit. In fact, the circle system's resistance is much lesser than the resistance offered by the narrow tubes that we put into the trachea of pediatric patients. The resistance of a full canister, adult canister, is less than 1 to 3 centimeters of water at 60 liters per minute. Yes, historically in olden days, specific pediatric canisters were present like the Hoyo, Blomqvist, and Revel circulator. I have never seen them or used them. So in modern days, an adult canister can be used safely in pediatric patients, provided you're using 15 mm pediatric tubings and a small reservoir bag, and you are monitoring adequately. Please ensure that while you're using the adult canister, you should avoid using coaxial circuit, and you should not use the jumbo canister. You should use the adult canister that occurs with a modern anesthesia workstation. I checked up with my pediatric colleagues, and they tell me the lowest patient that they least weight patient that they have ventilated on a circle system using the absorbent that is available there, the canister that is available there is 1.5 kg. So you can safely use an adult canister for a pediatric surgery system. When to change the absorbent? Obviously, you have to change the absorbent when the soda lime indicator is exhausted, or when the EtCO2 tracing does not reach baseline. And this happens when you are using it for a long time. What happens? The EtCO2 increases and the FiCO2 increases more than 5 millimeter of mercury. And also do not keep your soda lime canister without using it for prolonged times. Closed circle system offers several advantages. It maintains relatively stable inspired gas concentration. It conserves respiratory heat, moisture, and anesthetic gases, eliminates carbon dioxide. And when you're using low flow, it prevents the operating room pollution. The disadvantages are it is complex design containing several individual parts that can lead to misconnection, disconnection, obstruction, and leaks. Malfunction of unidirectional valves can lead to life-threatening hypercarbia, and anesthetic degradation can occur. Anesthetic circuits, the closed system has to be checked every day and also before every procedure. Three things have to be checked. One, you have to verify whether the carbon dioxide absorbent is exhausted or not by looking at the indicator. Second, you have to check for the leak test, high pressure system, high pressure leak test. You close the outlet of the Y-piece and then you activate the pressure, the fresh gas flow to produce a pressure of 30 centimeter of water. And then you cut off all the flow, and this 30 centimeter of water should be maintained at least for 10 seconds to ensure that there's no leak. And to ensure that the unidirectional valves are working, you do a 2-bag test, one reservoir bag, and the other bag you put on the Y-piece and you move. Alternatively, you compress both the bags and you see if the unidirectional valves are working properly. The unidirectional valves can also be tested by the inhale-exhale test by blowing in or blowing out into this and checking whether the valves are working well. Or you can use a suction bulb, which should remain collapsed if you're using it on an expiratory valve and should inflate quickly if you're using it on an inspiratory valve. The APSF has got certain recommendations to safely use the circle system. Turn off all gas flows when the machine is not in use. Change the absorbent regularly. Change the absorbent if color change occurs. Change both the components of the jumbo absorber, not just one canister. Change the absorbent when you are uncertain about the state of hydration. That is, if you have used FGF for a long time or you have not used the circle absorber for a long time. And if you're using a compact canister, change them more frequently. In modern workstations, the soda lime canister, the APL valves, here, the pressure sensors, the bag, the scavenging system, and the ventilator all occur as one unit. And it's really compact unit, but it requires to be tested. And most of the modern anesthesia systems, workstations are able to test the system by themselves. I thank you for a patient hearing, and I hope I've covered most of the important components of circle system that you'd probably want to hear. Thank you very much.
Thank you, Dr. Naheed Azhar, for the informative lecture. Can we go to the questions in the chat box?
Yes, I'll answer. I'll take those questions. Can you hear me?
Yeah, sure.
Yeah. I will take the first question by Dr. Prema.
Yeah.
She asks whether what should you do with the circle system in a COVID scenario. So in a COVID scenario, the patient is COVID positive. What we are trying to protect are the personnel inside the theater. Okay, that is the primary thing. So you should have an exclusive OT for COVID patients. No other patient should come there, and any person who's working in there should don their PPE and follow all precautions that are necessary. With regard to the machine itself, I think the best thing you can do is you have to make sure you use HME filters on your machine. You can use one HME filter at the patient end and probably one at the inspiratory limb. And also the soda lime, if you can use a disposable canister, that will be a good idea to do, because then you can, after every case, you can just dispose away the canister and start with a new canister. The other thing that we tried is, where is the possibility that the COVID can spread from the patient to us is from the gas that comes out from the APL valve into the atmosphere. So what we do, we put a plastic bag. If you don't have a scavenging system, we put a plastic bag. We take a pipe so that the scavenged gas or the gas coming out of the APL valve is taken, led to a container containing a strong disinfected solution where the virus will likely to get destroyed. So that is what we have been doing. While doing that, we also have to remember that if you are using a monitor with a side stream EtCO2 monitor, from there also there is a port where the extra gas will be may be returned to the circuit, it's not a problem. If it does not get returned to the problem, that gas also has to be led to a container with a strong disinfectant that's likely to damage the virus. These are the things that we have practiced with our COVID experience. The second question was by, I think, by Dr. Nimi. She asks, what is this concept of regeneration? Can it occur? Regeneration is an indicator. Let's say we are using a Mimosa Z. It starts off as a pink color. When it gets utilized, it becomes white color. Can this go back to pink color, although the soda lime has been used up completely? Yes, it can in older soda limes. The older soda limes that contain sodium hydroxide and potassium hydroxide, how does the reaction start? The reaction starts by sodium hydroxide and potassium hydroxide first reacting with carbonic acid. So potassium carbonate and sodium carbonate are produced. This react with calcium hydroxide to produce calcium carbonate. But the sodium hydroxide and potassium hydroxide are regenerated. When they are regenerated, they change the pH on the surface of the granule back to normal, and therefore the dye can once again become pink, showing you that the absorbent looks normal. The indicator will look normal. But if you look at your EtCO2 tracing, it will show you that the carbon dioxide is not being absorbed properly. Therefore, indicator changing its color back to normal can occur in older soda lime that contain sodium hydroxide and potassium hydroxide. In the newer soda lime that do not contain sodium hydroxide and potassium hydroxide, this change cannot occur. And this change specifically is called as regeneration or peaking. There was another question just now. Let me look at that question.
Yeah, that's by Dr. Sherin Maria. Can you see that question?
Yeah, yes, I have seen that question. See, how do we use our circle system? Actually, circle system can be used as a completely closed system. Only if it is a completely closed system, we can use it for low flow anesthesia. For a completely closed system, what should happen? The APL valve should be completely closed and the leaks in your entire circuit should be less than 150 ml per minute. Anything more than this, it is not safe to give low flow anesthesia. So what is a semi-closed system? The circle absorber has a functionality based on the FGF you use. If you use an FGF less than 1 liter, it is called as a completely closed system. If you use an FGF between 1 to 3 liters, it is called as a semi-closed system. In semi-closed system, what do? You open the valve a little, you keep the flow rate between 3 liters, and then you ventilate. So you can see that the APL valve is slightly open, so some amount of wastage is taking place. But large amount of rebreathing exhaled gas is still being used. So I believe that most of us anesthetists use our circle system as a semi-closed circuit. And using it as a semi-open circuit is when you use flow rates more than 4 liters. And using flow rates more than 6 liters on a circle system is an absolute waste of time. Okay, I hope that answers the question. Then there is a question about dead space changes. So the dead space in a circle system, all circuits have a dead space. That dead space is called as an apparatus dead space. Now let's assume you have a Y piece at the patient. This is your inspiratory limb and this is your expiratory limb and this is the limb leading to the patient. Okay, all dead spaces in breathing circuit occur at the place where the inspiratory limb, inspiratory fresh gas and the expired gas from the patient meet. So the dead space should be till here. But what happens is actually if you see, the dead space will extend a little bit into the inspiratory limb as well as the expiratory limb. It will be till here. So it'll start here and it'll extend till here. Why does this occur? This phenomenon is called as backlash, which I explained. What happens is when you press the inspiratory limb, the time taken for the inspiratory unidirectional valve to open and the expiratory unidirectional valve to close takes a little time from the time you press. So till that time, the expiratory gas coming from the patient tends to flow in both the inspiratory and expiratory limbs for a small part. That is why your dead space, instead of stopping exactly at the Y space junction, goes a little extra into the inspiratory and expiratory limb. So your dead space will start at the patient end and go till here. And this is called the backlash. That is the dead space of a circle system. HME filters. The next question is, where will you place the HME filter? I think I would like to place the HME filters in 2 places. One at the patient end near the Y piece, which means the gas coming out of the patient is filtered for viruses there itself. Then we also want to make sure that any virus that escapes from there does not affect your circuit and your circle absorber. So we put a HME filter just before the gas entering the expiratory port. That is where it enters and goes to the soda lime. There we put a HME filter. So that's the 2 places where we use the HME filters. Is that okay? Have I covered all the questions? I've covered all the questions. Anything else?
Yeah, thank you, Dr. Nishad Ahmed. And but there is a compliment to you from one of the great teachers, CL Gurudat. You can read it. Good evening, everyone. Excellent lecture.
Actually, I take my inspiration a lot from Gurudat. He is one of the best teachers among a lot of them who inspire young anesthetists, and in fact is a source of inspiration to me also. Thank you, sir, for your kind words.
Yeah, that's sure. All of us are inspired by Dr. Gurudat. So also he has helped so many students to clear their exams.
No, there is another question that asks, is there a coaxial circuit other than universal F? In a circle system, as far as my knowledge goes, and as far as the literature I have seen, only this coaxial circuit is available universal F. I've used it. I find no particular advantage in using it. So I like to work with the two-limb circuit. That I find is easier for me. Shall we call it quits? You have another lecture following.
Yeah, thank you, Dr. Nishad.
Thank you very much.
Thank you, Nishad.
Before we proceed to the next talk, a few announcements to make. We have a scientific session on 30th of March, hosted by ISA Malappuram City branch. The topic is post-operative visual loss, an underrated nightmare for the anesthesiologist. And the speaker for the day would be Professor Dr. Baburaj, who is additional professor of anesthesiology at Trivandrum Medical College. And the moderator for the session is Dr. Brijesh Ravivarma from MES Medical College. We have another academic program again on the next day, that is 31st of March, where the topic is online literature search and review. The speaker is Dr. Uma Hariharan, and she's from Dr. Ram Manohar Lohia Hospital and Atal Bihari Vajpayee Institute of Medical Sciences, Delhi. And the moderator will be Dr. Sudhish Kannan, who is professor of anesthesia at Bangalore Medical College. So now we move on to our next session, and the next session is ultrasound of the airway, and it is going to be delivered by Dr. Joseph Rajesh, who is currently professor and head of Department of Anesthesiology at Indira Gandhi Medical College and Research Institute, Puducherry. And he's done his MBBS from SRMC Chennai and MD Anesthesiology from Government Medical College, Mysore. He has many publications to his credit, and he is a regular faculty and a resource person for most of the workshops. Over to you, Rajesh, sir.
Is it ready? I am ready to record.
So you can share. Yeah, you're audible. There's some disturbance.
Okay.
Some disturbance is there, sir, in the audio.
Is my screen visible?
Yes, sir. Screen is visible.
Yeah. Okay. Thank you, Dr. Binal, and I thank the organizers for this wonderful opportunity. And
Sir,
thank you,
Rajesh,
sir.
sorry to interfere. Rajesh sir, sorry to interfere.
Yes.
Some echo is coming. So can you just change the mic?
Is it okay now?
Could you please talk something, sir? It was
Is it-
some disturbance
how is it
was
now?
coming earlier.
How is it now? Still?
Even now it's there, sir.
Is it still it is coming?
Yes, little bit.
I will try to do something for that. How is it now?
I think better, sir. Just
Better.
try.
Okay. Okay. Good evening, Dr. Bilal Isaac, and my sincere thanks for Dr. Venkatagiri sir for this opportunity. I was listening to Dr. Nair sir's lecture. Actually, it was very, very wonderful and very informative. I hope I would also like to try to live up to that standard set up by him. And when coming to this airway ultrasound, we all know that and aware that for the last decade, one decade, most probably in the last 10 to 15 years, this utility of ultrasound has become an integral part of our armamentarium. Be it utilization in the field of cannulation or performing blocks or assessment of different systems, be it a cardiovascular system to central nervous system, its utility has been confirmed beyond doubt. But when it comes to the field of airway management, a field which is considered as the forte of anesthesiologists, people do have some doubts about this utility. Partially, maybe because of lack of appreciation or lack of awareness or lack of acceptance, whatever it is. In that background, I'll start my session and trying to answer these two questions. The first one is, do we really need it? One, and if so, what is its role in the airway management? So actually, any technology that is going to be introduced newly is done for two reasons. Number one, that is mainly to reduce the human error so that the safety concerns are addressed. The second one is to improvise or to fine-tune the technology which we are already practicing so that the final outcome is better. In this case, if you take our airway assessment and management, so far we have been doing this with two issues. One is our clinical parameters and the other one is our radiological imaging. But the limitation what we come across these two parameters are, they provide us static information. They do not provide any of the dynamic or real-time information. This is where our ultrasound comes into picture. So my talk is going to try to answer these two questions. So our objectives will be, I'll give a bit of anatomy, what are all these structures and how those structures will look like to start with. Then what are the different views to get those structures and what are all the major clinical applications and what are all the best viable evidences. So with this background, we'll start. So what is the difference between doing an ultrasound in an airway when compared to all the other areas which we already do? The first and foremost thing which you'd like to know, or everyone is aware of this, that air is an enemy to ultrasound. And remember, our airway is full of air. Why air is considered as an enemy? When the ultrasound beam enters in any air containing structure or sac, this air does not allow the ultrasound beam to pass through. It immediately reflects it. Unlike other structures, for example, if you take our brachial plexus, where the ultrasound beams enter at different levels and get reflected back from the different depths. So it gives a real-time image of how exactly the structure will look like. But in case of an airway structure, whatever structure that is containing air, what happens, since the beam cannot enter beyond this point, it produces it reflects back. So when the air enters, our ultrasound beam enters through these different structures, it undergoes some sort of what is called as an acoustic impedance. This impedance varies from different structures to different structures. For an example, for the acoustic impedance of the soft tissue will be very less, but whereas the impedance to the air is very high. So the difference will be greatest when this interface is coming across. That is interface between soft tissue and air. This is called AM interface. That is air mucosal interface. Because of this high difference in the acoustic impedance, it produces what is known as this thick white or thick bright hyperechoic line. That's the first point everyone has to remember. The second one is, since all of the beam, US ultrasound beams are reflected beam back, whatever you see beyond this line is all artifacts, reverberation artifacts. So whatever structure present beyond this point, you will not be able to visualize this. Even though if you see some sort of a whitish hyperechoic shadows, all these are artifacts. This is what the first thing which we need to remember. Okay, so when we do the airway assessment with ultrasound, first we would like to know how each structure will look like. This is what the picture I have shown already, where this is the cartilaginous structures, this is the tracheal ring, then you have a air mucosal interface, and beneath this, whatever you see is the artifact, reverberation artifact, which is known as common type appearances. Bone, yes, bone also behaves like this because bone also doesn't conduct the ultrasound beams and all the beams are reflected back. As a result, all these bone structures like mentum or mandibular rami, hyoid bone, everything will look like a bright hyper-echoic structure with the acoustic shadows beneath it. But you will not see any type of shadows, any type of artifacts beyond this. And that is because of the acoustic shadow produced by this bony surface. How a cartilage structure will look like. So something like a tracheal, thyroid cartilage will look like a homogeneous hypoechoic structure. They'll be homogeneously hypoechoic. And whenever you see this type of a bright line, you can clearly think or you can clearly assume this is the place where ultrasound beams are reflected back by the air interface. That is mucosal and air interface, AM interface, which is popularly known as. Next, so having understood this basic concept, what are the different transducers we need to have an assessment of the air? So basically, when you talk about the assessment of the airway, it starts from mentum to the suprasternal notch. This is where our airway structures are lying. So as a result, we have to scan all the structures sequentially. For the practical point of view, this entire area is covered or rather divided into two, the hyoid bone being the demarcating place. Above the hyoid, it's considered suprahyoid area. Below the hyoid, it's known as infrahyoid area. The reason why hyoid demarcate this area is the transducers which are needed to scan this area is totally different. Because the structures of interest which are lying in the suprahyoid region are lying little bit in depth. As a result, a transducer, what is necessary to scan this area is a low frequency curvilinear. That's number one. Number two is you need to have a wide angle of view. So as a result, you can use only this curvilinear low frequency transducer. But whereas the infrahyoid region situation is different, here the structures of interest, whatever the structure we are going to scan, are lying mostly in the superficial area. As a result, our regular high frequency linear transducer is enough. In case if you have only one transducer, you don't have which is the available one, which is the ideal one, I would like to go with the high frequency linear transducer. This will do most of our assessment strategies. So now we have picked up our transducers. What are the views by which you can get the information about the air? So far, there are three views by which you can totally assess or you can scan the airway. First one is the sagittal view. Sagittal view is keeping this probe, keeping the probe longitudinally in the midline. So unlike the various, in other fields of our ultrasound practice, we used to have something like, if you take an echo, we call it as a flax view or sax view. So something like this. So whenever the airway is talking about, we have these three views. One is sagittal, parasagittal, and transverse. Sagittal view is transducer is kept in the midline, the longitudinal manner. Parasagittal is, as we all know, it is lying a little bit lateral to both sides to the central or median line. And transverse is keeping the view, keeping the transducer across. So these are the three views by which you can get the information of the airway structures. Okay. But you have to remember that if you see in this, since the area and transducers are not going ahead well, so there will be a lot of air interface will be occurring whenever you are scanning these areas. So as a result, you have to make sure that I already told you air is an enemy to the ultrasound. So to get a proper image, you have to make sure that the contact between the transducer and the skin is always good. So for that reason, either you may have to use a good amount of liberal amount of jelly, or some people even use what is called as a water bottle, water filled in some sort of a glove or some other pockets, so that can be used as a conductive medium. So what are the structures of interest we are going to analyze or we are going to assess during our assessment with ultrasound? It ranges from tongue, oropharynx, hypopharynx, hyoid bone, epiglottis, larynx, vocal cords, CTM, brachial cartilage, trachea, esophagus, and also the peripheral airway, that is your lung ultrasound and pleural ultrasound, including the diaphragm and other things. But I would like to restrict myself to the upper airway structures in this session. Okay, so how each structure of interest will look like. To start with, we'll just see how the trachea. So where to get the tracheal image? So this view is, you know that this is the transverse view, this is the sagittal view. So transverse view, we are doing it with the high frequency linear transducer, just kept just above the suprasternal marks. That is where you have to start your scanning. So when you keep the transducer just above the suprasternal arch, this is the view you get. This is the trachea, which can be identified by its shape. And what is that? It's something like a cartilaginous structure, hypoechoic. This is the thyroid gland, which is coming in the picture. And one more structure of importance in this field you need to know is the esophagus. Because I'll come to you later, what is the importance of bringing esophagus into this tracheal view is very, very important. So in the transverse view, we get the tracheal shadow like this. When you rotate the probe to the transverse, sagittal view, you get the longitudinal image like this. So this is the cartilaginous rings of trachea, and then you have the air mucosal interface, and whatever is lying beneath this is all our reverberation artifacts. It's not the lumen, actually, this is all artifacts. As you move your probe cranially, the next structure that is going to come across is the cricoid cartilage. So this cricoid cartilage can be recognized by something like an inverted C or inner horseshoe appearance. The hypoechoic in nature, and then you have an air mucosal interface here. This air, that is air mucosal interface, is the starting of the cricothyroid membrane. As you start moving your probe a little bit further cranially, you come across a V-shaped homogeneous hypoechoic structure. This is the thyroid cartilage. And this thyroid cartilage produces the best window for assessment of the vocal cords. So you see both the false and true vocal cords with arytenoids and anterior commissural top. And during phonation, you can see the movement of these vocal cords in this. And tracheal cartilage is the best window for analyzing or assessing the vocal cords. As you move still further, you see the epiglottis. Epiglottis is the hypoechoic. This is the epiglottis. Curvilinear shadow. This is the epiglottis. Known as the anterior to epiglottis, what is known as a pre-epiglottic space, and this is one of the most important indicator to predict our difficult airway. And beneath the epiglottis, you have a air mucosal interface. As you go further, that is cranially, you see the white inverted U-shaped image. This is nothing but our hyoid bone. Hyoid bone is the one structure which lies very superficially close to the skin, and the distance has to be measured, which plays an important role in predicting the difficult airway. So this is how hyoid bone will be looking like. During the cross section, that is your sagittal view, you get a cross section of the hyoid bone. Okay, so let's do the. I'll just show you a casual scanning of the image, and this starts from the hyoid. So you can see once this is the transverse view actually. So this is where our hyoid bone starts. You can start seeing the hyoid bone. We are moving from the hyoid bone to the caudally. So this is the, you can see the thyroid cartilage inverted V shape. The vocal cords are coming into the picture. You can see during the phonation, you can see the movement of the vocal cords. As you still further go down caudally, next will be, what will be coming next will be the cricoid cartilage. So cricoid cartilage start appearing in the vision. This is the cricoid cartilage with the air mucosal interface. Is exactly. As we go down, you'll start getting the thyroid gland in picture as well as the tracheal cartilage. Now tracheal cartilage start coming with the air mucosal interface. So now we have reached the suprasternal notch. So, okay, so having completed our infrahyoid scanning, then we will go to the submatrix, that is suprahyoid. The reason why we need to know something about this suprahyoid scanning is this is the area where we are going to have some predictors for our difficult airway. Normally, when we scan, we get to know about the layers of the mouth, floors of mouth, muscles of the tongue. or in case if you have any pathological process. These are the few indication or clinical application where you can get the information. So when you see the transverse view, this is how you get. What is more important here is what is the tongue width. So this is the tongue space. Actually, this is the tongue width. This is one of the predictor for our difficult type assessment. And this is the sagittal view. This is the mentum. This is a hyoid bone. So this is where the hyoid lies. So you get the hyoid bone here, mentum here. And for the cross-sectional area of the tongue, you can just get the calculate this area for the cross-section of the tongue to be calculated. Okay. So that is about the zone anatomy. So for a sequential scanning, you start from the mentum and go all the way to the suprasternal notch. The structure that is going to analyze or search to is going to observe was starting from the top tongue, then hyoid, then epiglottis, thyroid cartilage with the vocal cords, then comes down the cricoid cartilage, then ultimately the trachea. Okay. So once you know that, what are all the different clinical applications where this sono, your imaging is going to be used? In fact, there are a lot of evidences available about various clinical applications. I have compiled the most important applications where as an anesthetist, what we are going to be benefited. The most important thing is identification and localizing the cricothyroid membrane and confirm the tube placement, endotracheal tube placement and its positioning, or predicting the size of endotracheal tube or tracheostomy tube, and most importantly, how do you predict or assess the difficult airway, and also to pick up any abnormal finding. So let's start with the how to do or how to identify the cricothyroid membrane. So we all know that this cricothyroidotomy is the final escape step in the cannot ventilate or cannot intubate situation. And it is one of the most important technique each one of us should be familiar with. But unfortunately, in emergency situation, it has been found that the success rate of doing this cricothyroidotomy seems to be very, very low. The reasons being either we will not be able to identify the cricothyroid membrane for some reason, or even if it is identified, the placement of tube is not going to be in the proper place. These are the reasons that have been found in a study. Okay, why it is so? So that is why it will suggest in case when you come across a situation where you think of difficult airway, where you're going to be your mass ventilation and the intubation is going to be a problem, it has been suggested that you have to identify the cricothyroid membrane and mark it beforehand. But unfortunately, when you do this with the palpatory or a landmark-based technique, the success is very, very low. It goes somewhere around 30 to 35% only. What is the reason is, see, as long as you have a landmark like this, there's no issue. But unfortunately, where we come across a situation where we need to do cricothyroidotomy or something like that, always we have a patient like this. So when you don't have a proper landmark to identify a cricothyroid, definitely a cricothyroidotomy, the success rate which is going to be is definitely not very high. So this is where our ultrasound comes handy. It allows you to identify the cricothyroid membrane, that's number one. Not only that, it gives you an information how much is at what depth the cricothyroid membrane is lying. So by knowing the depth, you can very well plan your, when you are planning for a cricothyroid needle entry, you know that at what level you need to stop, at what level you can expect the function. These are the two most important information you are getting when you are scanning for the cricothyroid membrane. So how are we going to do that? There are two techniques described. One is doing with the longitudinal, that is the sagittal view, is popularly known as. It is the one which everyone have to start learning with, which is called as a string of pearls technique. Because the structure, what you are going to see, will look like pearl. If you don't have a space to keep the probe in the sagittal plane, then you have to do it in a transverse plane, that is known as a thyroid airline. Cricoid airline technique that is popularly known as a Trichloroethylene. So what is this string of pearls technique? This is a picture which I have already shown you. When you keep the probe in the suprasternal structure, suprasternal notch, this is the image you know. Now you must be familiar with the image. This is the tracheal structure. Actually, you have the tracheal cartilage in this ring. Then you have the air mucosa interface. Once you know that, next is you just mobilize your probe to the left and turn it sagittally so that you will start getting the view in the longitudinal. So when you mobilize or when you keep the probe in the longitudinal plane, the sagittal view, you get a air mucosal interface. Then you will get this type of 1, 2, 3, 4 curves. One curve which is lying in the superior most part will be sitting above. This plane will be much higher than when compared to all the other planes. This is the cricoid cartilage. So once you identify this cricoid cartilage, you move the probe little bit cranially, then you will see another bigger cartilage, and this is the thyroid cartilage. So once you know that, you can identify the membrane that is lying between this thyroid cartilage and the cricoid cartilage. So this is the cricothyroid membrane, and this is you bring it to the center and either you can bring it to the center and mark it, or you pass a needle underneath and you can follow the shadow which is going to be produced by it. Okay, so let me show a small video. So, okay, this is where we are starting. This is the thyroid gland. This is the trachea. Trachea is visualized in the transverse view. Once it is done, once you get this thyroid, and the tracheal view, turn the transducer to the sagittal view, you will start getting this. This is what is the string of pairs. So you know that this is the first tracheal ring, and this ring, this ball, which is sitting a little bit above when compared to all the other one, and this is the cricoid cartilage. Once you know the cricoid cartilage, you start moving it a little bit cranial. So once it is done, yes, you will start getting the thyroid cartilage. Once the thyroid cartilage comes in the picture, you know that this is the cricothyroid membrane, and this is the air mucosal interface, and this is where we are going to put our needle and enter the puncture the cricothyroid membrane. Okay, so how to do it in the Doppler technique? It's again same. You keep the probe in the transverse view. You get this is a hyoid bone. So once you get a hyoid bone, you move it caudally. So at some point you will get the inverted V shape cartilage. This is the thyroid cartilage. Once thyroid cartilage comes, you just concentrate on the superior most aspect where you start getting the air mucosal interface. So this is where you just start going down. You are moving it. This is where your cricothyroid membrane starts. Go down. Move it caudally. So now cricoid cartilage comes, and this is the cricothyroid membrane of the side of the cricoid cartilage. Once you know these two areas, you mark these two areas and go to the center point of that, and that will be the entry point for the cricothyroid membrane. Okay, so that's how we have to identify the cricothyroid membrane. In case of an emergency, we need to, it will take, actually the recent articles have clearly shown that the time taken for identifying the cricothyroid membrane is less than 4 to 5 minutes in a reasonably trained person. So the same technique can be used for identifying the tracheal ring or tracheal space where you need to do a PDT, a percutaneous dilatation of tracheostomy. So once this, what are the different information we are going to gain by doing this is, number one, you know that which is the optimal interface where you are going to do the tracheostomy. That's number one. Then you will know the depth at which your entry point is going to happen. That's number two. And if at all there any vascular structure or running, is there any aberrant vessel? By using a colored Doppler over here, you will identify any aberrant vessel, which is thyroid vessel, which are present. You can avoid that area. So further, you can confirm with the lungs. So the third important application is your confirmation of the endotracheal tube placement. So what is this actually? We know that we all know that the gold standard for confirming the endotracheal tube is by the ETCO method. But recently, it's been studies have clearly shown that yes, ultrasound assessment of the airway and confirmation of the endotracheal tube has got a role in certain special situations, especially in a patient who's apneic or a patient who's arrested, whose pulmonary flow is very low, or in an emergency situation. So how are we going to do this? So in fact, in a study where 100 emergency intubations are done, this study is done in India only, and they found out that the time taken for the confirmation by ultrasound is much lesser or much faster than the time taken by clinical methods or by the ETCO2 confirmation. So the reasons being actually, so in case if you want to confirm it by the endotracheal ETCO2 tracings, actually you need to have at least 3 or 4 breaths to get the standardized waveform in a standard manner. So this is not necessary in case of our assessment or confirmation by the ultrasound, because this confirmation of ET placement under ultrasound is a dynamic one. The moment the tube enters, we will be. So how are we going to do that? So there are definitely a lot of evidences available in this. We'll skip this and go to that. In fact, 2015 guidelines, the ACLS guidelines also claims that ultrasound can be used as the method for ET confirmation. Okay. So how are we going to confirm this? Our endotracheal tube placement. As I have already told you, this is a tracheal lumen, tracheal shadow. Whatever is present beneath this surface is all artifacts. So even if we have the tube here, you will not be able to recognize the tube. Then how are we going to know, or how are we going to come up and know that the tube has entered? So this is done by indirect method. That is, if we rule out a tube, this is the esophagus. If you rule out the tube entering the esophagus, you know that the tube is done, or tube has entered the trachea. This is how we confirm the ETT placement under ultrasound. So when you get this view, you have to make sure that esophagus also comes into the picture. So I'll show you how this is the picture. We know that this is the tracheal shadow and this is the esophagus. So now tube is being inserted. If the tube enters the esophagus, you will get what is known as a double track sign. So now air is present in both areas. So as a result, you will get what is known as this double track sign. So if this double track sign is not there, so you can be very well sure that tube has entered the trachea. Then another method by which you can do, these are all described, but not much evidence is available for this, using a color Doppler to find out where exactly the turbulence of air is happening. So if you keep a color Doppler in this tracheal lumen, you will be able to see this this type of artifact or the turbulence happening. If the same turbulence is happening in the esophageal side, you can be sure that this is actually the tube is in the esophagus. In fact, in pediatric age group, you instead of keeping the probe above the trachea or on the trachea, you can keep it on the thyroid cartilage, where you can see the widening of the vocal cords. That technique also has been described, but that will be useful or that will be possible only in the pediatric population. There is another method by which you can indirectly confirm the tube placement. That is the lung sliding. We all know what is this lung sliding. It is nothing but the movement of the parietal and visceral pleura over one another. So whenever the lung is expanding, you get the movement between these pleura, and this pleural movement is picked up what is known as, and is known as lung sliding. So if the lung sliding is present, we know that that side is being ventilated. So once you confirm the endotracheal tube placement, then you can further confirm it by keeping the probe either from first to third intercostal space. And if both sides you get this lung sliding, you can be very much sure that the tube is in place. Okay. So when compared to the other techniques, what are the advantages? Naturally, the ultrasound is easily available, freely available in the emergency medicine, emergency departments, where the monitor with the ETCO2 may not be available in many of the emergency rooms where the ultrasound machines are available. So it is easy to pick up this tube placement. And most importantly, these images are not affected by the low pulmonary flow, which is an important concern when you are resuscitating a patient with the who's at a cardiac arrest or in the low circulatory state. And third most important thing is, whatever said and done, to confirm the endotracheal ETCO2 tracing, you need to give 3 or 4 attempts of bagging. So this prevents, in case if you don't want to do it and you want to confirm it with the lung ultrasound, so this prevents the unnecessary forced ventilation to the stomach and its associated complication. These are all the advantages by which you can confirm the tube placement by the ultrasound. Okay, so now we have put the tube, and is it possible to rule out the endotracheal intubation? Yes. Here, again, the same technique, the lung sliding comes into the picture. So when this lung sliding, I already told you, lung sliding tells you that that particular side, whether it is the right side or left side, is the ventilator. So when this lung sliding is coupled with measuring the tracheal, the changes in the tracheal diameter at 2.5 centimeters above the suprasternal notch, you can clearly rule out endotracheal or endobronchial intubation. So in fact, this study has found that the sensitivity is good, 93%, the specificity of 96% when these two techniques are combined. That is, your plus the lung ultrasound with the pulmonary tree and lung ultrasound technique. So with this, they have found out that nearly when compared to the auscultation, it showed only 66% sensitivity. This technique goes well into 90s and specificity also into the 90s. Okay, we'll move on to the next one. So the third application is your airway measurement. Is it possible to measure the airways, which we are very much interested in? So yes, it's been done. A lot of studies have validated with the measurements, with the MRI and CT, and they have found good correlation with that. And this measurement is going to be very useful in predicting an ATT size in pediatric population, as well as the WM tubes in the adults when you are using for the lung isolation techniques. So what are you going to do is, actually, this is the subglottic diameter. When you measure the subglottic diameter and using this as a tool for selecting an endotracheal tube in pediatric population, this increases the accuracy of this selecting a correct size to 98% rather than the age-based or height-based formulas are being used. So this reduces the airway-related or other the improper size tube complications. Same way, the outer tracheal diameter can be used when you measure this just above the sternal arch. This can be used to determine the size of the WM tube. And this is the formula given by the, it is a little bit different from the one which we have already seen. We all know the Brodsky formula, which tells you about the, that is based on the CT scan image, but this is the ultrasound image where you can, if the tracheal outside diameter is more than 21.2, you can safely go for 41 size the WM tube. Okay, so what next is the prediction of the post-extubation stridor. So this is one of the dreaded complications we come across in the ICUs mainly, especially when the patient is being ventilated for a long time. So we know that what we conventionally do is we check the cuff leak. If the cuff leak is adequate or if you're happy, we will go ahead and expect it. But studies have shown that even with the 100 ml of cuff leak test, the patients are going to have post-extubation stridor. So what they have done is they have measured the depth between the inflation, this is the laryngeal air column. So depth, I mean the diameter between the inflation and deflation. And if the ratio is going to be less than 0.8, yes, you are going to, there's a high possibility that this patient will develop post-extubation stridor. So even though the cuff leak test is okay, you have to, the ratio of 0.8 or less, there's a high chance that, a high possibility that the patient will have post-extubation stridor. So coming to the assessment of the difficult. So naturally, whatever studies we have done in the, or whatever the assessment we have done in with the ultrasound of the airway, unless we translate into the prediction of difficulty, it's not complete. So what are the parameters that will help you to predict the difficult airway? What are the different ultrasound parameters which we are going to use for? There are many parameters, starting from the supra-hyoid parameters and infra-hyoid parameters. Either the tongue volume or base width of the tongue, the distance from the skin to various structures of interest or the epiglottis or the hyoid bone or mento-hyoid distance. There are many parameters have been taken and many researches have been done. And there are a lot of, these are all the different types of images you can get. This is the pre-tracheal shadow or pre-tracheal space or the skin to the hyoid bone and pre-epiglottic skin to pre-epiglottic space. So this is for the tongue volume studies. And they have taken different parameters and they have come with the varied results actually. So these are the most important studies. It's all available and you can, all of you can go through this. You can pick up the different types of parameters and ultrasound guided parameters and their results are varying. But one thing what I would like to tell you is this is the most important study which has been done last year, which tells you that what they have done is they have taken two groups. One group that entirely is the clinical parameters. That is your mentohyoid distance, subluxation, that is the upper lip bite test, then hyperextension. So they have divided into two groups. One group have got this score, and the other one is ultrasound-based SED, that is the skin to epiglottis distance. So they have studied these two groups. So, and the area under curve of ROC gives 0.763 accuracy when only the clinical parameters are taken into consideration. But when this single additional parameter of the ultrasound is added to this group, that accuracy increases, that area AUC increases to 0.928, which is close to 1, which is very, very good. So the ultrasound parameter of here definitely is going to complement our pre-existing clinical parameters. So we have to use it wisely. So there are a lot of anecdotal reports available about various other uses like confirmation of the laryngeal mass supraquatic devices and whether it is malrotations and presence of the cuff, all those things the reports are available. So this is the recently done case. Actually, this we can assess the vocal cord movement. So you can see that immediately this is a thyroid case done, and immediately after the extubation, you can see both vocal cords are moving, but they are moving very sluggishly. But after some time, about 15 to 20 minutes, their improvement, their vocal cord movements have become a little better. So why I want to tell you this is actually this we can do away with our mandatory scopic assessment of the vocal cords after the thyroid surgery. So if you are able to assess the vocal cords with ultrasound, yes, we can avoid the unnecessary scopies. So this is the gland compressing the trachea. So we know that by assessing it dynamically, we know that whether this gland is at what level this is going to compress and what is the diameter of the trachea at this time. All this information we can get. So I would like to complete with one classical case presentation, which we had some time back. This case clearly tells you that in what way or how it is going to be very, very useful. The ultrasound of the airway. We had a patient, a 72-year-old female with the thyroid swelling came to us, posted for the thyroidectomy. History was except that mild hoarseness and dyspnea, but not much of significant. But during the clinical examination, we could not palpate the trachea. That's the first thing which made us a little bit worried. So we want to know where exactly the trachea is. So we did the ultrasound. The moment we kept the probe, he did not find anything. We just got some white shadow, most probably vertebrae. So when we moved it laterally, we found that trachea is there actually. So when the tracheal diameter is measured, it was very, it is restricted. It's compressed 0.77 or 7.7 millimeter. So this gives us two important, this ultrasound of this trachea gave us two important information. The one is, so the scanning is being done. So the first thing is whether this trachea is expandable, the expandability of the trachea. We all know that whenever when the patient, if you are going to mass ventilate a patient, if suddenly if you are not able to ventilate, we were thought that you have to pull the gland out. But we will not be very sure that is going to solve the problem. But yes, you can confirm it with the trachea. So when with the ultrasound, when you pull the gland a little bit side, the trachea expanded from 0.77 to it has gone to 1.31. So we know that at this time we know that this trachea is expanded, or the compression can be minimized. So the next most important thing is where exactly this trachea. Now, in case if this patient has to undergo emergency tracheostomy or emergency cricothyrotomy, where exactly the puncture has to be made. So when the the classical position when the transducer is kept, I told you this is what we got. This is most probably the vertebral bodies. And when we start moving the probe laterally, so nearly about 5 to 6 centimeters laterally, we started getting this classical picture of the cricothyroid cartilage and cricothyroid cartilage. So we marked it, and this is where the trachea is present. These are the cartilage. This is where we mark, and this is confirmed by the when we went ahead with the fiber optic. We found that the same place where the trachea is. So for some reason, if this patient has to undergo cricothyrotomy without a heart tracheostomy, without ultrasound, this is definitely not possible to do the tracheostomy here. So this is the finding which I would like to share with all of you. So definitely, yes, ultrasound of the assessment, I mean, airway assessment has got a most important role. So to summarize, we know that this is one of the most exciting recent technological advancements. So various clinical applications are found the ultrasound utility, like it increases rate of CTM location and the procedure. So ETT, the electrical tube placement, can be detected a little bit fast, and it's possible in select patients. It provides most valuable information before going ahead with ER or PCT. And it is also used to detect endobronchial intubation and more accurate to predict ETT size in children, and also the WM tube size. And for difficult airways concern, it improves the accuracy when an ultrasound parameter is coupled with the clinical parameter. So the take-home message is, yes, it is one of the most powerful tool in the hands of anesthesiologists. We have to use it wisely and efficiently. Thank you.
Thank you, Dr. Rajesh. Thank you, Dr. Joseph Rajesh, for that wonderful presentation and for highlighting the use of ultrasound in the management of airway. And it's a relatively new topic, especially for me. And I really enjoyed the talk. Thank you so much, sir. And I think there will be some learning curve for doing this. No? There will be a
Yes, actually, it is said that if you are already familiar with, I'm sure that most of us are familiar with doing the blogs and other things. So it will not take much time to learn the maybe you have to spend some time in the anatomy dissection hall to exactly understand the structures where exactly lying. Once you get a hold of it, it is not a very big. The learning curve is not very big.
So can we take a few questions? I think
Yes.
Come in the chat box. There's a question in the chat box asking about the ideal position of head for measurement of these airway parameters.
Yes, actually, the ideal position, I would say, that is except the hyomental distance. Hyomental distance, hyoid mental distance, that is what they do it in two different positions. That is, when your HMR, that is hyomental ratio, is done in both normal position as well as the hyperextended position. And then calculate this HMR this. Apart from this, about that particular parameter, all the other are done in the sniffing position. This flexion of the neck and extension. This is what you have to do. And only for the HMR, you need to follow these two positions. Otherwise,
so do you regularly use this in your
not regularly. When we know that there is going to be some problem. Actually, initially when we started learning, yes, we were trying to get the information. But once we are reasonably okay with doing the thing, only when the cases like thyroid comes, yes, we do that. And when we expect some sort of complications, yes, we do. If you have an ultrasound in the department, it is easy. Initially, you have to start doing with all the patients to get just a hold of it. Next question.
Well, there are no more questions in the chat box. They have said it's an excellent presentation.
Vijay sir, actually, the participants can unmute and they can ask questions directly.
Yeah, that will be good.
So those of you who want to ask questions can please unmute. We have made that possible. So please do take this opportunity. So you said it is possible to measure the measuring the size of the DLT. You can use this technique. So can we use this technique to identify lung isolation, not the airway?
That is actually, this is the second time I'm coming across this question actually. In another forum also the same question was asked actually. So initially we never had a fiber optic bronchoscope when we were doing this lung isolation technique. So at that time we used to find it, this ultrasound used to be very helpful. Theoretically, if you see, yes, it is possible to detect the lung isolation. But practically the problem here is, see, when the patient, we know that the lung sliding is dependent upon the pleural movement. We all know that. But when the patient comes for the some pneumonectomy or lobectomy, we are not very sure about the quality of the pleura. So suddenly, as a first step, after introducing the WM tube, if you are going to assess, you may find it a little difficult. because that side, most of the time, the lung sliding will be absent. So we will not be very sure that whether that side lung is isolated. So what you need to do is you have to do it pre-operatively. So you have to do it pre-operatively, make sure that this lung sliding is present on both sides. Then after the DLT is positioned, if it is absent at that side, yes, you can assume that that side is. So first, that is the small hitch you need to follow.
Thanks. So what would be the best parameter, in your opinion, for stating that this would be a difficult airway? What would you suggest?
It's a very difficult question, actually. So there are a lot of parameters have been studied, actually. The accuracy or sensitivity, when you are taking one individual parameter, it doesn't go above 66%. But when it is coupled, it goes up. The area under the high sensitivity goes up. So if you want to take as a single parameter, I would say that HMR, that is hyomental distance ratio, or the pre-epiglottic space, that is skin to epiglottic distance. These are the two parameters that can be considered, that can be. Then some people have done with the tongue volume, assessment of the tongue volume. You take the width and cross section of the tongue, multiply. If it is more than 100, studies are different. Somebody say that more than 100, some of them are saying that more than 130 cubic centimeter. So these are the few parameters which can rely. But you know that the sensitivity of the Malapati grading is about 66%. But when it is clubbed with this, it increases to 96%. Then maybe we may have to have further studies to exactly to pick up one particular parameter which will tell you that yes, this is present, this patient will have it. I may not be able to answer right now.
Thank you, sir. Any questions from the postgraduates or the practicing anesthesiologists? Please do ask. You can unmute and ask. Well, I think you have shown us beautiful pictures, and probably we have no questions. Anyway, thank you,
Dr.
Rajesh. Yes, there's one question.
For a person who is new to this, which is the best position to assess a patient for ultrasound of the airway? Is it supine or sitting?
Supine. It is supine position. Always start learning with the supine position, and because you'll get a lot of information. But sitting, actually, sometimes what happens is placing the probe becomes a little difficult. When the patient sits, actually, you may not be able to keep the probe exactly like that. So always start learning with the supine position.
Okay, thank you, sir.
Thank you. So some more question on the measure the volume and cross-section area of the tongue. What exactly is the question? How to measure?
Yeah, that is how to measure.
Yeah. So how to measure is basically you need to get the submandibular scanning. First, you get the transverse view of the tongue, and you find out what is the diameter, that is width. So if possible, if you are lucky, you will get the lingular arteries actually in both sides. So between this is your width. And once you get the width, then you do a sagittal scan. In the sagittal view, you get the tongue, and your software will give you what is the cross-section area. So multiply this cross-section area with the width, that will give the volume of it. Is it convincing? Got it? Okay. Any other questions?
I think there are no more questions. Anyway, it was a wonderful presentation, sir, and with all those.
Thank you. Again, my sincere thanks to the organizers, especially Venkatagiri and Daniel and all the organizers. And I think this is a privilege given to me, and really I'm honored. Thank you. Is there any remarks, sir, Venkatagiri sir?
Nothing from my side. Last that you have took that. Thank you very much for your time for us and give this talk to It's more PG oriented, not more, it is PG oriented and for the PGs to take benefit. And we are new to this ultrasound and all. And just I am also learning. We have got a machine now, slowly. It was very difficult for me to do that. I think I will have to go somewhere and learn that the needle placement was needle and looking at the needle and that is online, offline and all, really difficult to go somewhere and learn that. The new things we have to learn, we are getting that. Only by attending this and practically we can know that. People, it is a part of their, now it is for us, we have to learn.
Thank you, sir.
Thank you. Thank you.
Thank you. I thank our speakers for the excellent presentations. And our president is there for concluding remarks. Nasa sir, please.
Yes, sir. Good evening. That ultrasound talk was really excellent because we are all people doing a lot of regional work. I thought it's a stimulus for us to start the airway ultrasound. We'll start doing, and when we start doing, I'm sure that we'll have a lot of questions maybe we discuss later. Thank you.
Thank you.
The first part, definitely it was a postgraduate discussion on a closed system. That also was really excellent. Thank you all, both the speakers for the wonderful contribution and a very good lecture. Thank you all.
Thank you, sir. Thank you very much. And shall we conclude the session then?
Rajesh and Vijesh, shall we conclude?
Yeah, sure. It's time to conclude.
And Vijesh sir, do you want to announce next week's session?
Next week we have a session on drugs, actually. Drugs in anesthesia. We're planning to take it as a 3-part session. And probably the speaker is going to be Dr. Sanish. He's going to be the speaker. And we have students from Amala Medical College who will be the panelists for the session. And also we have Dr. Paulo Rafael from Amala Medical College who will also be there in the session. So all of you can please do log in at the same time. And we have a very important exam-oriented session that is on drugs.
Thank you, sir.
Okay, thank you all. We are concluding. Good night. See you.
Good night.
And thanks to Joseph sir and Nahida sir for their excellent presentation. Thank you, sir. Thank you.